Good afternoon. Welcome. Welcome to Building Public Interest, Health Disparities, and the Pandemic. My name is Kara Hendrickson. I am the Executive Director at BPI. BPI is an independent public interest law and policy center where we address compelling racial and social justice issues that impact the Chicago region and the state of Illinois. Through our advocacy, we work to drive racial, social, and economic justice through a focus on police accountability, reform of the criminal legal system, housing and community development, and education and early learning. To work towards systemic change, to make systems more equitable, we collaborate with community partners to ensure that those living in under-resourced communities have access to life opportunities. Redressing structural racism is fundamental to BPI's overall social justice mission and central to all of our work in our core program areas. BPI's goals in each of our areas of our work focus on the fundamental structural inequities in major societal systems. In order to do this work, in order to catalyze the change and to build equity in societal systems, we are launching a new series. Today's panel discussion is the first in that series called Building Public Interest. Through it, we set out to inform, educate, and activate a wide and diverse audience around issues of social justice, racial equity, and their inherent intersection with other areas of concern that impact us all. We take our inspiration for this intersectional approach from American civil rights activist Audre Lorde, who famously said, "There is no such thing as a single issue struggle because we do not live single issue lives." It's not a coincidence that we are having this panel discussion today on February 16th, centered in the middle of Black History Month. We name this time as an opportunity to both celebrate the triumphs of Black Americans and the cultural heritage and successes that are a part of our country's history and present day, and also to train our focus on the persistent and ongoing legacies of racism and their impact on Black and Brown communities. We'll focus this conversation today on public health, which is, of course, also at the center of so much of our day-to-day lives as we turn into the second year of the COVID-19 pandemic. Today, we're focused on health disparities in the pandemic. Before I introduce our panelists who will join us, let me just set the stage a little bit with a little bit of data. We'll hear more about this as our afternoon goes on, but just to start with some data. In Chicago, African Americans account for about 29% of the population in our city. But in the COVID-19 pandemic, African Americans have suffered 70% of COVID-19 related deaths of those whose ethnicity is known. Across Illinois, the statistics are similarly stark. African Americans are 15% of the population in the state of Illinois, yet 43% of deaths and 28% of infections have been among African Americans. This is not a structural issue that is unique to the COVID-19 pandemic, as we'll hear more about. Even before the pandemic, Chicago had the largest life expectancy gap in the country, according to an analysis of the largest 500 US cities by the NYU School of Medicine. Residents living in the Streeterville community of Chicago, which is 73% white, live to be about the age of 90 on average. But just 9 miles away, in the community of Englewood, which is 95% Black, residents only live to be 60, the report found, on average. So we see a stark 30-year gap in life expectancy in communities, segregated communities in the Chicago community. So we're going to start this conversation with the notion of health equity. We'll talk today about access to health care, but we'll also talk about a broader idea of health equity and some of the barriers to it. We'll focus on structural racism as a cause, a lack of investment in communities, and concentrated poverty as some of the social and structural conditions that contribute to health inequities in Chicago and in Illinois. There are remedies and solutions and steps that we all need to be talking about and taking action in these areas. We'll talk about that as we move forward. But I want us to recognize it's not just the healthcare system alone that contributes to some of these stark inequities that we'll be discussing. We're going to ground this conversation today in an important premise. And the premise is that every person should have the chance to lead a long and healthy life. I can't think of two better people to help guide us in this conversation today than the panelists who are joining us this afternoon. I'll take a minute to introduce them before we turn to our conversation. Our first panelist joining us today is Professor Rokhaya Yerbi. Professor Yerbi is a professor and a member of the Center for Health Law Studies at St. Louis University School of Law. She is also the co-founder and the executive director of St. Louis University's Institute for Healing, Justice, and Equity. Recently, Professor Yerbi received over $2 million in grant funding from the Robert Wood Johnson Foundation to study the equitable enforcement of housing laws and structural racism in the healthcare system, including an enforcement of housing laws and structural racism in the system overall. Using empirical data, her research explores the ways in which discrimination prevents vulnerable populations from attaining equal access to quality healthcare, resulting in health inequities. Her literature and her scholarship couldn't be better formatted for today's conversation. Some of her reports that she's authored and co-authored include Racism is a Public Health Crisis, Here's How to Respond, Protecting Workers that Provide Essential Services, Health Justice Strategies to Combat the Pandemic, Eliminating Discrimination, Poverty, and Health Disparities During and After COVID-19. Her work has been cited in numerous scholarly publications and articles and anthologies. She earned her BS in Honors Biology from the University of Michigan, her MPH from Johns Hopkins School of Public Health, and her JD from Georgetown University Law Center. Professor Yerbi, welcome. Thank you for joining us this afternoon.
Thank you. Thank you for having me.
Our second panelist joining us this afternoon is Anna Crane. Anna is an Associate General Counsel for the Office of Illinois Governor J.B. Pritzker. She advises on litigation, legislation, policy, and agency operations on a wide portfolio of issues with a focus on access to healthcare, reproductive health, healthcare facility financing and regulation, and public health. She works closely with the Department of Public Health and other state agencies on all aspects of the state's COVID-19 response. She has also worked on several key legislative and policy initiatives, including the legalization of cannabis and clean energy legislation. Prior to her current role, Anna served as public interest counsel to Illinois Attorney General Lisa Madigan, where she handled multi-state litigation and policy initiatives to defend reproductive rights, access to healthcare, and various civil rights and consumer protections. She previously worked for the U.S. Senate Committee on Commerce, Science, and Transportation, where she conducted congressional investigations with a focus on consumer protection and health insurance practices. Anna was selected for the 2021 Edgar Fellow Program at the University of Illinois Institute of Government and Public Affairs for her leadership in Illinois government. She is a graduate of Northwestern University and the George Washington University School of Law. Anna, welcome.
Thank you, glad to be here.
So pleased to have both of you with us for this conversation this afternoon. I'm going to start by asking Rokhaya, you to help us set some of the stage and the context for our conversation this afternoon. We know when we are diving into complex issues of structural racism, that history and context are important for us, particularly as we're talking about an issue like public health. We are all living in what we think of as an emergency, a public health crisis. But tell us a little bit, if you would, about the state of public health equity before COVID-19, and tell us what's happened since we've entered this COVID-19 pandemic.
So a lot of my work around this is actually in employment, but I want to start with something that is closer to people's daily needs and begin talking about access to clean water. So before COVID-19, we see access to clean water was unequal. In particular, an estimated 1 in 10 Indigenous Americans lack access to safe tap water or basic sanitation. We can see that also in urban areas, looking at San Francisco, in their Chinatown. We see many of the buildings lack a bathroom. And in fact, in one story published in The Guardian, they talk about how on one floor, 60 residents share the bathroom, but that because it is out of order so much, they actually, one of the residents actually uses a plastic potty that we usually would see for children. We can see this in Mississippi with the outages. And what that means is that because people lack access to clean water and sanitation, right, they cannot ensure that they are protected against COVID-19. They can't wash their hands, they can't use the bathroom, and it's only gotten worse since COVID-19. In an article that I published in May 2020, we actually saw and can look at the map and zip codes, which show that predominantly Black zip codes lacked access to clean water and had the highest rates of housing violations, which include lack of access to water, toilets, kitchen facilities, and that also was where we saw the highest rates of COVID-19 infections. So to me, that just shows an example of how historically we haven't done a good job of providing people with access to clean water, sanitation, and that has just sort of gotten worse as we've gone through COVID, as some people have been evicted or had their water and utilities shut off, even though they can remain in the home.
I'm going to ask you to back us up a little bit and help us ground us in public health generally. When some of us think about public health, we think about going to the doctor, we think about going to the hospital, we think about acute healthcare needs. We talked a minute ago about some different public health outcomes we are seeing, statistically different outcomes based on race coming out of the COVID-19 pandemic. Help us understand, if you could, all the pieces that really relate to thinking about public health and how those relate to these outcomes.
So most people do consider sort of public health as healthcare. It is not. They actually are separate. They should be combined, but in a way that understands that things outside of healthcare actually lead to poor health outcomes. So when we think about housing access, when we think about employment, living wage, paid sick leave, transportation, when we think about all these other areas, they impact our health just even more, one would say, than actually just having access to the doctor after you are harmed, right? And so particularly in Illinois and Chicago, where I used to live, right, there are high rates of pollution, which could lead to increased rates of asthma. That's what we're thinking about in public health, not just you actually going to the doctor and getting some access to medicine to treat that asthma. But in public health, can we address the things that make you unhealthy so you don't have to go to the doctor?
Anna, let me turn to you. Tell us a little bit about what we are seeing in public health in Illinois. How has the state of Illinois thought about public health historically? How's the state of Illinois thinking about it today, including in the imperative to address equity caused by the COVID-19 pandemic?
Sure. So, Illinois, like other states and areas of our country, obviously suffers from and has created in ways these health inequities and disparities across the state. And you can see in a lot of the work that the state does in the healthcare side of things, actual access and treatment to care, sort of trying to look at those more root causes and put it into context. Because as Dr. Yerby mentioned, when we think about trying to get better care to people, we have to look at the ways, the barriers that exist, or the hesitations, or the infrastructure that that may not be available to people who really need the care. So, in Illinois, we have, this work is, in terms of the government, is sort of spread out in many different ways. And one of the things that the state does is a report every 4 years. It's a statutory report about the state of health in Illinois. And the goal is to sort of look at the state of health across the state. Where are areas that we need to focus our resources to improve our health? And then also within that general assessment of what is the state of our health, how can we focus on areas that are already have inequities and are going to need that extra resources? How can we focus to make sure that we're meeting the populations who need additional resources and access to care than others? And how are we setting up systems that do not create greater health disparities? I think as you talked about in your introduction remarks, Kara, we see inequities in life expectancy in Illinois, as well as infant mortality rates. Are big disparities in some of the areas that we can focus on and see sort of at early stages in life, where do we have inequities between, particularly with Black and Brown communities, the rates of infant mortality are, much higher than in white populations. And so we can see these disparities in many different ways in Illinois.
Yeah, can you tell us a little bit more about then what? As the city and the state collect this data and this assessment happens, how then are the data points and the inequities that are identified in the data points then translated into action that's taken with respect to the data that is shown?
Sure, I think that happens in many different ways. So the state, for example, we are a big funding source of things. So as we look at how we're going to spend Medicaid dollars, for example, or we're going to spend grant money, looking at that data as a baseline to say, where are we going to put these resources? It also should inform how we regulate things. The state has a role in where hospitals open, for example, looking at that data to say, what is the need? What areas of the state don't have maternal or obstetric care, for example, and making sure we're kind of evaluating that as we sort of act as a state player. And then I think very importantly in our sort of like, the resources that we assert just in programming as the state. For example, the Department of Public Health has been working to implement what they describe as, a health equity checklist, which sounds sort of light, but really it's incredibly important work to say every time we have a grant, every time we're going to spend dollars, who is this program targeting? How is it going to reduce disparities? And how are we going to avoid creating more disparities? So it factors in a variety of ways. And I think COVID in particular has forced us to look at how can we do that more often and how can we do it more quickly and be more responsive to the data.
Great. Okay, in your opening comments, you packed in a lot of different concepts when you were talking to us about public health being not just about healthcare. I'm hoping we can tease out some of those intersections and those interrelated pieces that drive some of these public health outcomes. So I'd like to just start with just one of them, if we can, and maybe we can walk through a few of them. And that's employment, to really start to dive into the issue of employment. Why should we be thinking about employment as a public health issue?
Well, for many reasons. So when we think about access to healthcare in the United States, the main way that people gain access to healthcare and health insurance is through their employer, right? Employer-sponsored health insurance. And so that's one of the ways that it impacts people's ability to seek the care that they need. Second of all, during COVID-19, I think it's become more and more clear that the lack of benefits benefits, including paid sick leave, and living wages impacts people's ability to stay home and when they're sick, and to also take care of people who are sick or perhaps their children. And so those are ways that really link employment to people being able to make the choice about being healthy. One other thing that is mostly overlooked, and I want to highlight some of the work done in Chicago by a couple of doctors at Northwestern, is that work and work stress often impacts people's health and well-being, and also is connected to infant mortality and low birth weight babies. So Richard David, James W. Collins at Northwestern did a lot of this great work back in the late 90s, early 2000s about Black women, particularly in having low birth weight babies, which is one of the precursors to infant mortality. And they talked to the women and found that they were suffering a lot of stress and employment stress about worries. Would they have time off? Would they be fired? And so that needs to be taken into consideration if we are trying to address and deal with health disparities, particularly for infant mortality, for women, and generally, because employment is a big part of our life, and the stress from employment impacts our health, both positively and negatively.
And Rakaya, you and Anna and I are all lawyers here on this panel. BPI is a law and policy center. Can you tell us a little bit about how the state of the law impacts employment as well? How our laws were drafted, when they were drafted, for whom were they drafted? How do they impact employment, do you think, and this issue of public health?
So one of the things, going back to paid sick leave and some of the benefits for essential workers that are predominantly racial and ethnic minorities and undocumented immigrants, initially they were left out of those protections. So going back to the New Deal era, 1935, the National Labor Relations Act that provided union rights for most workers, allowed for unions to discriminate against racial and ethnic minorities if they were covered. But the law also exempted out domestic workers, service workers, and agricultural workers. And those are the workers that are primarily essential workers. About 20% of all essential workers fall into those categories, and probably even more, because the domestic workers also include home health care aides, personal aides, so people who provide services in nursing homes and home and community-based care. So they didn't get the union rights. They don't get paid sick leave. They haven't actually gained a lot of union rights. They also were left out of the Fair Labor Standards Act, so they don't get a living wage. They're not covered under the 40 hours a week and overtime. And when we look at COVID-19, some of the bills actually left out these workers purposefully because it was explicit. We're not going to cover undocumented immigrants, who primarily are agricultural workers, meat and poultry processing workers. They also explicitly left out home health care workers because they didn't want a worker shortage. So you can see the ways that law, either neutrally or with clear intent to leave out these groups of workers, has impacted people both historically and continuing throughout COVID-19.
Thank you. Anna, I'm going to come to you on this, on essential workers. We have, for the past 2 years now, been alternatively celebrating and lifting up, relying on, and in some cases overlooking essential workers. They've become a topic of conversation. Can you tell us a little about the state of Illinois' response to the COVID-19 pandemic, particularly as it relates to essential workers and generally protection of people during the COVID-19 pandemic?
Sure. So, thinking sort of early on in the COVID-19 pandemic, when we first started, the language of a stay-at-home order sort of entered all of our lexicon, the idea that we might be shutting things down, the the questions that the states and everyone was evaluating is sort of what, how do we do this in a very basic way? Because we know there are things that have to continue, and that puts people at risk. Because people have to go to work when others don't and can stay at home. So I think the way the state has addressed this is, and often or sometimes in partnership with the federal government, right, of what funding resources are we making available to ensure that people can have leave, that they can stay home when they need to, they have childcare when they need to, and there has not been perfect solutions on those things. By any means, but I think the way that we think about it in this state is providing protections where we can. There's been a lot of discussion about paid leave, about sick leave, about ensuring people have access to childcare if they have to go to work when their children are at home. And so that has been a top conversation and top of mind throughout COVID-19. There's also been, as we saw, I hinted at this before, as the state thinks about how we respond to these different issues, thinking about some of the, funding that did come through for workers who were unemployed or whose hours were reduced. And so maybe they were not at risk because they were not going to work, but they no longer had the income they needed because of everything that has happened. Making those systems work and making them accessible, and that people know about them, and that we are finding the individuals who need those resources. So it's been a real challenge for sure to implement new protections sort of in the space that we're in right now.
I want to turn to talk a little bit about housing. Professor Yerby, this is lifted up certainly in some of your scholarship, and you mentioned it in the context of evictions early on. Is housing a public health issue? Can you tell us a little bit about the intersection there between some of the conditions that you described earlier in your comments and the systems that create housing and how they do or don't protect against public health outcomes?
Yeah, so we in public health view housing definitely as a public health issue. Unfortunately, the courts have not necessarily considered it a public health issue, which is why you saw when the CDC, the Centers for Disease Control and Prevention, issued an eviction moratorium, that it was challenged and then rolled back in the courts because it wasn't viewed as a public health issue. But the data shows differently. So throughout the pandemic, we have seen increased rates of infection when people have been evicted, which to me is quite clear. If you can't stay locked down, if you don't have a space, right, to stay away from people, you're more likely to be infected and spread the disease. It has not necessarily been a focus, a leading focus, I think, of public health. In some ways, right, we definitely have tried to focus on lead abatement, which has been a big issue throughout cities, including Chicago, Cleveland, and other places, to try to ensure that homes, particularly with children, do not have lead in them. But that really is the only federal law that governs a lot of the housing conditions. And I'm just talking about in terms of public health, right? There's no federal law that talks about habitability and right to water. Those are really local and state laws. So you have different requirements at that point. But it's also a disconnect. And what I would say that we need to do better in public health is also to connect to civil rights laws, including fair housing. And so we need to think about the ways that people discriminate, particularly against families, women with children, and how that leads to poor health outcomes for the women, the children, which then leads them to needing to see physicians, leading to perhaps higher rates of asthma and other chronic diseases. And so I would say definitely housing is one, but it is so disjointed in the regulation, and we need to do a better job connecting it also to civil rights issues of discrimination against women, children, people with disabilities, and other communities.
Because I think what I hear you saying is really it's two, at least two parts of housing, right? It's access to housing. Can you get housing? Can you keep housing? And also it's access to housing that has conditions that promote public health. Can you say a little bit more about those conditions? You've talked about lead paint and how our regulatory infrastructure has really lasered in on lead paint. What else should we be thinking about when we think about housing conditions as a public health issue and a civil rights issue, as you said?
Definitely access to water, access to housing that doesn't have mold or other things that can increase people's sickness, vermin or cockroaches. When I was in Chicago, one of the issues was that in predominantly Black neighborhoods, there were higher rates of asthma. And guess what? There are higher rates of cockroaches, of things that increase people's risk of having asthma. We also need to think about access to electricity because sometimes that is not something that is available. And I think this has come to the forefront, particularly as we've seen in two places, I think New York and Pennsylvania, where we have fires that destroy buildings and kill people, in part because they're not having sufficient heat or electricity for people to plug in heaters. And so it is the overall conditions that perhaps we take for granted in where we live, but people are allowed to actually rent out those things. And it's not to say, once again, that those laws aren't on the books, perhaps in the city, county, and the state. The question becomes, are we enforcing those laws? So before people rent out things, are we enforcing those laws that ensures that the people living there actually have these things? And are we doing it so that they can live there, right? So if we enforce the law, perhaps now the rent goes from $200 a month to $2,000 a month. That does not help people gain access to housing.
Anna, I know that housing is something that the state of Illinois has also been thinking about. Can you tell us about how this issue of housing and access to housing has been addressed by the state in the COVID-19 pandemic?
Sure. Illinois, we put our own eviction moratorium in place, separate from the CDC moratorium. I believe ours extended a little beyond the CDC one because of the court rulings. But, thinking about the breadth of things that we did early on in the COVID-19 pandemic to enshrine some protections, in many ways, I think some of them surprised people, but often they were very much closely related to public health. When you were speaking, it reminded me, we also put a moratorium on cutting off electricity and heat for the exact reason that people can't stay at home if they can't turn on their heat in the middle of a Chicago winter. And so that nexus between housing and COVID is so obvious to me, and was something we did think about quite a bit during COVID-19. There was also, increased rental assistance to help people stay in their rentals, and trying to make sure that people are not losing housing in the middle of a real crisis.
I want to pick up on this theme, Anna, that I've heard you raise, and Rakaya, you as well, and that's about the connectivity of these issues and the awareness of that connectivity. Anna, you just shared with us, seeing these connections, understanding why access to electricity is a public health issue is something that is plain to you. And Rakaya, you have shared for us just the straight line between civil rights, various societal structures, public health outcomes. Do you think that this connectivity that you're both sharing with us this afternoon is also playing to people outside of this conversation? Are we adequately sharing information about the connectivity of these structures and public health? Do you think that there are things that we should be collectively working to address as we see so much controversy around public health mitigation efforts in the COVID-19 pandemic to really be providing education about the interrelatedness of these issues? Or do you not see that as an issue? I'm just really interested in your reactions outside of the work you do, the reaction that you see to some of these actions by the state of Illinois and by others, and where, if you think there's a piece that we're missing collectively in our societal conversation about these issues. I'll open that up to either one of you. Rakaya, I don't know if you want to start.
I can start because I see Anna saying, go ahead. I think to me, the problem is that during COVID that we have really taken on a medical lens. And a medical lens means that we focus on an individual that's impacted and not a community that's impacted, and the ways that we are interconnected and impact each other. And so that's why we need to do certain things. And so from a public health lens, we have also adopted the individual perspective, which is problematic. And so I'm hoping that people understand that it's not just you getting COVID, it's your community and how does it impact you? I think for me, what I've tried to let people know and understand is from a perspective of vulnerable individuals who are not protected unless we wear masks or do things, and that's kids, right? As people often talk about, we want kids to go back to school, that is not really going to work well if we don't undertake some of these measures to protect them, particularly as some kids still remain unable to be vaccinated, right? And some kids who have disabilities or immunocompromised cannot go back to school if we don't adopt some of these measures. And so what I would say, sometimes that helps, sometimes that doesn't. But what we really need to begin talking about is the ways that we as a community are impacted by individual choice, which is very different than when I go to a doctor and talk about high blood pressure or, what should I eat? Or do I need to lose weight, right? That is a choice that I make mostly. But it is very different when we think about a disease that is often changing, right? And changing because we continue to not undertake measures to help each other.
Yeah, I would just add, I think that COVID has started putting this interconnectivity on people's radar and public health in general, obviously, than it had before. What comes to mind for me is, as we saw like the vaccination rollout, for example, and who was able to access a vaccine appointment, who had internet access and time to sit and find an appointment early on in the pandemic. It was the digital divide that we often think about in sort of a consumer space, sometimes in an education space, but now you kind of see, well, that's also impacting people's ability to get care or to know about resources in their community, because that was a primary way that information was flowing. So I think there has been a lot more awareness of how non-healthcare issues, traditional healthcare issues, are impacting our public health. I think we have plenty of ways to go in that space. And from our perspective, kind of as the state, as government, I think one of the ways that we have tried to really increase that awareness is really genuinely engaging with communities where we're seeing, low vaccination rates or low testing rates or high case rates, for example, and trying to understand, okay, we can look at the data, but what's really happening? Why are people not coming to the site? Is it because they have work and they can't come to get a vaccine appointment? Is it because they don't trust the information that they're hearing? Is it that they purely didn't know that it was available or that they were eligible? And so trying to understand better the disparities that we're seeing and getting at the root reasons, I think, is creating that interconnectivity in a way that is just sort of heightened with COVID.
I want to just note for our audience that I am really enjoying this conversation. I have so many more questions that I want to ask the both of you. I'm going to do that for a few more minutes, but if you have questions that you'd like to pose to our panelists, I see some are already coming through in the Q&A. We will turn to questions from our audience here in a few minutes. So go ahead and start putting those in the Q&A to ask questions to our panelists here as part of this really rich conversation. We'll turn to that in a few minutes, but first I want to turn to the question of healthcare itself. You know, you've educated us that public health is about so much more than healthcare. It's about some of the things that we've talked about and much more, but I don't want to lose the thread of healthcare itself as part of the public health infrastructure. Rakaya, I'm wondering if you can talk to us about whether we see racially disparate inputs and outputs in our healthcare system itself. So access to care, outcomes when care is sought, doctors and healthcare professionals and medical professionals. Do you see that as part of what contributes to some of these racial disparities that we see in public health outcomes?
Yes, but we have been focusing on that for, I would say, 30 years, and not really also focusing on the structure of healthcare and how that even if we had the doctors, all the doctors wanted just to give people care and they gave them the same level of care, that there would still be disproportionately poor outcomes for people of color, for women, people with disabilities, LGBTQIA individuals. And that is in part because there is no right to health care in the United States, right? It is really based on, do you have insurance and can you pay, except for if you go to the emergency room and you are actually suffering an emergency. Now, that still is a problem, particularly when you're in COVID and you go to the emergency room and they're already filled up. Things that used to be an emergency are no longer an emergency. And so our system is set up so that people cannot get access to care, going back to what Anna said, right? Unless you have some privilege, you have some insurance, and you can actually go to a healthcare facility because it's located in your neighborhood. When I lived in Cleveland, actually in the middle class and upper income areas, affluent areas, there was a clinic almost on every corner. It was like Starbucks, right? Because they are home to Cleveland Clinic, University Hospitals, Metro Hospitals. And so you could go to get care and wouldn't have to travel that far. But in poor neighborhoods, they didn't have the same access to healthcare. And you see that playing out during COVID-19 because that's where we set up our testing. That's where we usually set up our vaccine distribution, and that's where people are getting care for COVID. And so it really is beyond just the bias that we focus on with individuals that we all have. It also goes to the structure of the system where people are not able to access the care that they need. And the last thing I would say, even when they have federally qualified healthcare centers or clinics in those neighborhoods, sometimes they do not have the resources or the test or the vaccines to give out to people in those neighborhoods.
Yeah, how about it in Illinois? Can you tell us about access to care in Illinois And I'd love to lift up what Professor Yerby has said about access to clinics and that, but additional health infrastructure as well. Can you tell us about how we're doing in Illinois in terms of access to care?
Sure. I mean, access to care is a major priority, you know, of several of the agencies that I work with, and thinking about how are we funding, authorizing, incentivizing care to be provided in different areas. So an issue that comes to top of mind, particularly in Illinois and in Chicago, has been access to hospitals and closure of hospitals. As we've seen consolidation amongst healthcare systems, particularly hospital systems, you know, profit is a big component of these systems. And so we see closures in communities where the facilities are not as profitable. So we have to think quite a bit in Illinois about how we are incentivizing those facilities to stay open. And that's very hard to do. You know, one initiative that we're embarking on, and it relates particularly to the Medicaid population, is the idea of healthcare transformation and building different collaborative systems that are connecting hospitals and doctors, primary care clinics, as well as community service providers, so that they are working in tandem and that they are focusing their resources so that people can get care. So, you know, our Department of Healthcare and Family Services identified 5 areas in the state of Illinois, 4 of which are in Chicago or surrounding Cook County, that have the highest vulnerabilities on the CDC index of healthcare social vulnerability index, and trying to really focus on getting more collaborative and comprehensive systems into those communities so that people have not just access to a hospital, because once you've gotten to a hospital, things have gone really badly already, especially if you've made it to the emergency department. So trying to find ways to get access to a primary care provider before you have to come to the hospital for COPD or asthma, for example, is really important. And we are looking for, you know, different ways to incentivize and create those systems.
Can I jump in really quickly? Because I wanted to highlight that. I saw that bill was actually passed in Illinois, and I was excited about that. And one of the things that you didn't mention that I want to highlight, because as I mentioned, I'm focused on employment, was that part of it was also to ensure that the hospitals and the systems took a look at what they were paying workers, and to ensure that that was also a point of equity, right? Because sometimes the people that you are serving in those communities are actually workers in those hospitals or those clinics. And so if you ensure equity with their pay, their benefits, that can also lift up and address some of the health disparities that are happening.
Great. I want to turn to some of the questions that we're receiving from our audience. There's a lot of interest in what can be done. And what can be done to start to address some of the issues that you've raised. So Professor Yerby, one of our attendees, wants to know about whether there are efforts that look at the holistic issues that you've raised to ensure that there's a strategy to address public health concerns that COVID-19 has brought to the fore for many people.
Yes, I saw this question and I was thinking hard about how to answer it. And I could not think that to a lot of examples, but let me try to highlight the work that I know that is going on. And so I know sort of in the academic realm, there are people who are coming together to start pushing for health justice. And so that brings in this community focus social movements, right? The lessons from civil rights, the lessons from the reproductive justice and environmental justice movements of having communities lead the change that we need. And so I think that is one great aspect. And so Professor Angela Harris has written about this, Lindsay Wiley, Seema Mohapatra, Emily Benfer, who actually started her career at Loyola Chicago School of Law, focusing on housing issues and lead. And so I'm excited about that because it's bringing together people to link education and how that impacts health to criminal justice and how that impacts health, but not doing it just from a sort of the academic perspective, but people's lived experiences. And I want to highlight another person in academia who's sort of doing this, Shamila Michener, who studied Medicaid and talked about how Medicaid actually is tied to people's voting, right, and their power, because they feel so disempowered through Medicaid that actually shows up in their civic engagement and voting. And so I know that there are organizations out there doing a lot of this great work. And maybe if you email me, I can email you those links. Actually, you know what? There's one, the Praxis Project, and it is in California, and they do amazing work. They work with community and really try to push this community-led and governments adopting impact assessments. And I did think of another one. So talking does help. So Barhai, which again is in Oakland, is a group of county health departments that are working together to do health impact assessments and really to work to think about how housing and all of these issues interconnect. Lastly, there are places, cities and counties using racial equity tools. And what that does is that means, as Anna was saying, right, you want to move forward with the policy. And so you think, how is it going to impact people differently? So if we're going to move forward with minimum wage, that's great. But once it is implemented, did it actually help everybody? And so we can do an audit to see, does it help everybody based on race, based on class? And so those are some of the ways that I think people are moving forward.
Thank you. Anna, I want to turn this question to you as well, and maybe pick up where Rakaya left off. We have a related question in the chat about models, right? Municipal models, whether they're cities or regions or other governmental entities that you say making notable progress in public health, that have models that they're putting in place. And maybe, you know, as you are part of the leadership in the state of Illinois, as you all are hitting the books and thinking about the approach that the state should take, you know, where do you draw inspiration? Where do you draw models and success stories that can help us learn and build on what's happening around the country during this pandemic?
Sure. You know, I'm similarly kind of blanking on specific examples, but one thing that I would say is, you know, talking about our process in finding those models and thinking about how we figure those things out, I think we are continually striving to not always come up with that decision on our own of like, this is the model we should follow, but really trying to be thoughtful about the communities that we are trying to really serve, and what do they see, and what are the problems that they identify and barriers they have come across, and what models kind of address that. I think we have really, especially during COVID, and I think this is work that always happens more broadly but can be continued, is convening many different types of stakeholders, not only having hospitals in the room, right, when we're talking about healthcare policy, but having community service providers, having small businesses, having, you know, housing advocates, having people with many different perspectives to bring to the table the issues that they see, and building our approach based on those many different perspectives is incredibly helpful. With COVID-19 in particular, we had a pretty robust task force that kind of crossed the spectrum of organizations, and then we focused on particular issues. You know, we had a migrant worker work group. I was thinking about what are the issues that are particularly affecting this community. And then we had groups focusing particularly on data transparency, or data collection and transparency. So having all these different perspectives and who can help us sort of evaluate what other places are doing and what fits for Illinois and for different communities is incredibly important in our work going forward.
And picking up on that, Anna, I have a question about language as a barrier. We haven't we've perhaps talked around a little bit, but haven't this afternoon really talked specifically about language. And so I'm wondering, you know, for either one of you, how should we be thinking about sharing information about English language as a barrier to the various components that we've talked about that go into public health determinants and to access to the public health system overall? Do you see that as a barrier? And if so, you know, how should we be thinking about addressing it?
Well, I'll just sort of kick off here. I mean, we think about that a lot as we do not only education campaigns, but resources, how people can sign up and engage with the healthcare services that we've provided in COVID, for example, has been very front and center of our decision making. And I know we have, across the state, again, sort of looked to different stakeholders to help us inform, like what are people not hearing from us and how are we not reaching people? And as we think about things like setting up a vaccine clinic or a testing site, is there someone on site, or what are we going to do if someone comes and cannot communicate in English? And can we get that person? Because if we have to turn them away, we have likely lost them. And so we don't want to have that happen in any circumstance.
And I would just say really quickly, one of the places that is using racial equity tools, Seattle, Washington. So as part of their operation, they are supposed to take racial equity into consideration. And so they even do it with their public housing. And so when they had to fix an elevator, they thought about, okay, who lives in this building? And let us make sure that any information we put up is translated in their language and available for them. And so that's going back to the prior question of just thinking in advance. Okay, where am I going? Can I provide resources for everybody that is going to be impacted? And can I just bring, even at every vaccine place, just, okay, let's make some flyers that has it translated in every language that we think will be impacted in this community, and just make that available. So.
We only have 3 minutes left, so I'm going to turn to each of you for one last question about silver linings. If you could identify in 1 minute or less, whether COVID-19 has really created, if there's a silver lining to being in the midst of this global pandemic as it relates to racial equity and public health, is there any good that has come out of this pandemic that we should be identifying and working to grow? Anna, I'm going to start with you. I see Rakaya smiling, so I'm going to give her a minute. Anna, what silver lining has come out of the pandemic?
I would say that one of the silver linings on this front is pushing some of our systems to acknowledge that we need to be more nimble. We need to be more flexible and responsive. We are big institutions, whether it's government or healthcare, and we're used to being slow, and we're used to taking a long time to evaluate and get approval to change direction, right? COVID accelerated things so that we were making changes on the fly in hours and days as opposed to months and years. And I think a silver lining of that is that we are seeing how important it is to be listening and be responsive and constantly evaluating and not waiting years to see what the outcomes are of what it is that we do. So maybe that's a silver lining.
I'm going to answer it a little differently. I think it has made it clear that there is a call to action for us, that during COVID-19, it's not just about protecting people from getting infected with COVID-19. It's also ensuring that people who have the least can get access to resources. And unfortunately, right now, we see across the country that there are challenges around that, particularly around being able to protect people. In lots of states, they're rolling back public health powers, they're rolling back discussions about critical race theory, and all of them are connected in the sense of, if you can't track COVID and you don't have the power to do that, you also don't have the power to track the salmonella outbreak, right? You don't have the power to track and see if it's impacting one community differently and to get those resources there so it doesn't spread. So I think what COVID-19 has said to us is that there's a call to action and that we should be working together across not just the issues that maybe, are dear to our heart, like environmental justice, but that also impacts, right, racial and ethnic minorities, children, people with disabilities, and we should be working all together.
Calling us in to action. What a great way to conclude our time together. I really take to heart this call for us to peel back the layers. We started our conversation this afternoon with some pretty stark statistics that laid bare racial disparities in our public health system. And we have worked here in just 60 minutes to peel back the complexities and the layers. And the call in to really look hard at root causes, as you've both talked about, is so important for us to learn about and to take that call to action and to pick it up and to work forward on changing some of these really deep entrenched systems that contribute to the outcomes that we're seeing and are highlighted in this pandemic. We know that our work is not done then. I think you would have both agree saying when COVID-19 is over, we really move to our next phase of work to continue to address many of these root causes. Thank you both so much for joining us this afternoon, Professor Yerby, Anna Crane. Really, your insights and your teachings and your call to action is so valued, and we appreciate your voice in this conversation, and wish you and all of our other attendees a good afternoon. Thank you all.